Welcome, everybody, to the 6th Annual Virtual Support Group Leaders Summit. My name is Chantel Wicks, and I'm the Regional Manager of Community Engagement and Development here at Myeloma Canada. I am pleased to welcome Dr. Joshua Richter, who is the Associate Professor of Medicine at the Tisch Cancer Institute, Division of Hematology and Medical Oncology. He is the Director of Multiple Myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai in New York, not in Toronto. I know we hear Mount Sinai and we think Toronto, but Mount Sinai in New York. And he is here to speak to us today about understanding and navigating relapse and treatment options, which is a topic that we've heard from our support group leaders is something that's quite important and is a hot topic today. So welcome, Dr. Richter. Thank you for being with us.
Awesome sauce. Thank you so much. Yes, New York, but very excited to be joining our lovely neighbors to the north. Please don't hate your neighbors to the south. We apologize for pretty much everything that we do. But yes, going to talk about myeloma, get through a lot today, and then answer some questions. But let's see if I can get computer to working. Okay, so how do we choose therapies for myeloma? And the reality is that there are many diseases nowadays that it's very clear what to do. Either everyone agrees that a certain therapy is the best, or there are genetic markers, meaning there's a mutation. So, there may be mutations in different genes like EGFR or HER2/neu, and we know that using specific therapies in those patients work best. But in myeloma, we don't have that. And especially in the relapse setting of myeloma, where we have many options, there are three main dimensions that we use to choose a therapy. One is patient-related factors. So is the patient old or young, fit or frail? What comorbidities do they have? Disease-related factors. Is the disease growing fast or slow? Is it high risk? Is there extramedullary disease? And treatment-related factors. What treatments have you had? What have you not had? What are you naive to, sensitive to, or refractory to? And what about route of administration? So this all has to factor in. So why is this so important? Because despite the fact that there are many, many options for myeloma, the average person only gets around 3 to 4 lines of therapy. Now, there are good reasons and bad reasons for this. The good reasons is that many of our older patients will get such a deep remission that, if you look at modern day induction regimens that have progression-free survivals of around 100 months, someone may only get 1 or 2 lines of therapy and pass from something else. But, we still have younger patients with higher risk disease that we do need to worry that there's about a 25 to 35% attrition rate with each line in myeloma. So it's really important at every what I call inflection point. Every time there's a relapse or a need to change therapy, we need to make sure we optimize everything because we don't have an infinite number of options or an infinite number of drugs or an infinite number of lines. So we need to make every decision as informed as possible. And there's a number of different schemas that have been put forth to help kind of figure this out. And this is a wonderful one by one of our good friends, Niels van der Donk. And this is really looking at some of the core ways that we think about how to manage myeloma at first relapse. Again, patient disease characteristics are very important. Availability of drugs, and this is something that will differ from country to country. There are different therapies approved in Canada, in the US, and other parts of Europe and Asia and Africa. So we need to figure out what's available, what the guidelines are. And then this kind of first branching point is what are you refractory to? To me, it's not just about refractory or not, because you'll see here lenalidomide refractory versus non-lenalidomide refractory. And my question is, how do you do with lenalidomide? Meaning, if we recognize that pomalidomide is another drug in the same class as lenalidomide. If lenalidomide was part of your upfront therapy and you've been in remission for a decade and the disease is coming back, sure, pomalidomide can be part of the next regimen. But in my mind, if you underperform with Revlimid, meaning I put you on a Revlimid maintenance and 3 to 6 months later the disease is coming back, I don't know that I'm going to go with Revlimid as the next option because I think it's time to class switch. Now, one of the most important things we have to definitely consider is approvals and algorithmic pathways in each individual country. Now, my understanding, I used to call this, I think this used to be called CADITH. I used to say CADITH taketh awayeth and CADITH giveth. But now it's CDA, and this is the kind of funding algorithm for the different options in the Canadian landscape. And this is really important, not just because it's not which regimen is better than which regimen. It's really trying to take a step back and think of myeloma like a chess game. It doesn't just matter what your next move is, but what's the move after that and the move after that. And the reason that I bring this up is a number of years ago, there was this big presentation at one of our meetings of what's called the Aspire trial. This was Kyprolis, Revlimid, dexamethasone versus Revlimid and dexamethasone in early relapsed myeloma. And the triplet was better, and everyone was excited. And then one of the questions that was asked, and Keith Stewart was presenting this, so another Canadian, um, well, I guess Scottish Canadian, Canadian. Um, Someone asked him, well, okay, KRD is better than RD, but what percentage of people had access to Revlimid and to Kyprolis in the relapse setting if they got RD? And the answer was 2%. And what I took away from this is not necessarily that three drugs is better than two. It's access to more therapies is better than access to fewer therapies. So, we look here and I think in our minds we can think that some regimens may be better than others. But the question is this a really good move in chess that kind of binds our hands in the next move? So making sure that we have good options throughout the course, again, at least through third or fourth line, really, really important to make sure everyone gets access to all the good drugs. So again, when we look at the upfront paradigm in Canada for newly diagnosed patients, even more so than the US, we make that decision of are you transplant eligible or transplant ineligible? And at the moment, Darzalex or daratumumab is only approved for patients who are not going to proceed with high dose therapy. But if you are going to proceed towards stem cell transplant, the current options are RVD and CyBorD. Then we get into the relapsed paradigm, and this is where things get a little more complicated and where we really need to look for, you know, what therapies are you refractory to? Are you refractory to Len or Dara or Len and Dara? And that really impacts the next course of therapy. Because, for example, if you've never had Len and Dara or you're Len and Dara sensitive, let's say you got Cybor D up front, auto transplant, Revlimid maintenance for a few years and then stopped, and then a few years later relapsed. You're still sensitive to Len, you're naive to Dara. DRD may be the optimal therapy for you. If you're refractory to Len and Dara, you want to bring in newer mechanisms of action. So either another proteasome inhibitor like Case ID or two new mechanisms of action like selinexor, Velcade index. So really want to look at what drugs you've received, what you respond well to, what toxicities you have from them. And again, really trying to think not just what is going to be our second line therapy, but how does that impact our third line therapy? So, for example, if you go from Dararev Dex to XVD, well, we know that K goes after V very well, and POM can go after that as well. So we have the option of KD or POM-Cy Dex. If you get KD first, we don't have as robust data about the use of Velcade after Kyprolis. It's not that you can't do it, but if you look at the studies that were done with Kyprolis, they were done in patients who had prior Velcade. So, XVD may be a better option just so you can have more active drugs along the way. And again, looking at second line post ASCT. If you're still sensitive to Velcade, what about Dara Velcade? What about Isakyprolis? So, it really makes myeloma a very complex landscape. Even though patients are only going to get about 3 or 4 lines of therapy, even as early as the first line, or maybe the second line more pragmatically, you need to start thinking about what that third and fourth line might look like and how to optimize things along the way. Again, don't necessarily save something for the eighth line. Unfortunately, not everyone gets to the eighth line, but at least trying to plot out second, third, fourth to figure out what is going to optimize things along the way. And again, ultimately, as T cell redirector therapy like CAR Ts and bispecific antibodies come down the pike, one of the things we're thinking of is that if that is going to be part of your therapy, we need to preserve T cell fitness. T cells are immune cells that help fight bacteria, viruses, and cancer. And if we're going to ask in the fourth line for a CAR T or a bispecific and ask those T cells to fight the cancer, we can't give you a therapy in third line that kills T cells. So one of the things to think about, or what I like to call the N-1 therapy, is that if you're considering giving something like that in the fourth line, well, in the third line, do you want to avoid alkylators like cyclophosphamide potentially? Drugs like selinexor, for example, can preserve T cell health. So, for example, if you got DVD in second line and then you finish the Velcade, remain on single agent Dara, now you're progressing, and you want to ultimately get to a T cell redirector in fourth line, XVD is a great option in third line. If you got ESA KD in second line, thinking about the incorporation of Palm Cidex in third line, and maybe if you're heading towards a T cell redirector at some point, back off on the Cytoxin. And again, I think I've gone through this ad nauseum, but really trying to figure out, the optimal pathway for each patient. And again, when we're getting to to later lines of therapy where patients are going to be Len and Dara refractory, but still may be PI sensitive, we do still have a number of options of places that we can go. Oh, okay. All right. Well, let's talk about some of the data in terms of what are our options when we get there. And I guess one of the ways to think about it is, what the backbone is. And, for many patients, Revlimid is going to be part of the upfront therapy. And oftentimes on paper, we plan to give Revlimid until progression, either Revlimid as maintenance after auto transplant or something like Dararev up front or VRD up front. But the reality is, many patients stop Revlimid along the way because of intolerance, because of cytopenias, patient decisions, the list go on and on. So we still have a number of patients that enter early relapse sensitive to Revlimid, in which case a Revlimid backbone is going to make the most sense. And here we see some of the four big phase 3 studies looking at Revlimid-based backbones in early relapse: KRD, ELO-RD, DRD, and IRD. Now, I mentioned the Aspire trial, and back then, when this got presented, the median PFS was around 26 months, which beat out some of the other regimens, which were just under a year. Then here comes the Pollock study looking at Dara-Revdex. Now we have patients getting a median, an average progression-free survival of over 44 months. So again, in my mind, if you're still Rev refractory, the next question is, what about CD38? Because have you been on single agent Dara? Well, DRD is not going to be your best bet. Something like KRD may be better. But if you are still sensitive or naive to Rev and Dara, Pollux has given us some of the best data in early relapse. DRD may be the way to go. Now, the reality is most patients, if you look globally, are going to be exposed to Rev. Now, this data doesn't include every country and it's a little old, but by second line, most patients have been exposed to Revlimid. And we recognize, and again, this is also old data. So I don't take this with as complete fact with these progression-free survivals, because this is 2016. This is before a lot of the therapies that we currently have. But the sentiment is still the same, which is once you become refractory to a drug, that is not as good. And just to be clear, the difference between relapse and refractory means progression on or within 60 days of your last dose. So if you're on Revlimid maintenance and you took it and you're on it and your numbers go up, you're refractory. If you're on Len maintenance for 2 years, you and your care team decide to stop it, and a year later your numbers come up, you are relapsed, but not refractory to it. So the important thing is starting to think about non-Revlimid containing backbones, because still many patients will remain on Revlimid as part of their upfront therapy, either in maintenance or long-term treatment, and then progress on it. So again, what happens when we need to class switch? Either you don't tolerate Rev, you don't do as well as we would have hoped with Revlimid, or based on approvals, we need to switch to a bortezomib-based regimen. Here are some of the bigger trials that we've used, phase 3 with PI-based regimens. So we have Castor, Endeavor, Panorama, Optimism, and Bellini. Wonderful names. And I'll point out a couple of things have changed. One is that panobinostat is not available in North America at this time. And venetoclax, although not approved for the treatment of myeloma, we recognize that patients that have translocation 1114 may very much benefit from this type of approach. So again, I think if it is at all possible in early relapse for a patient with an 1114 translocation to get venetoclax, that might be a great way to go. Endeavor, KD versus VD, in general, we've really moved away from doublet therapy in myeloma. So in my mind, better to give a dose-adjusted triplet than a full dose doublet. And the rationale there is that even though we think of myeloma as one disease within an individual, it's not. There are subclones. And usually at the time of diagnosis and throughout their journey, a myeloma patient will have around 4 to 6 subclones of their disease. And they all have different amounts in them and they vie for dominance. But what this means is that we know that anywhere in myeloma, from upfront, early relapse, late relapse, depth of remission correlates with durability. How do you get a deeper remission? Kill more subclones. How do you kill more subclones? More mechanisms of action. So to me, giving 3 drugs dose adjusted gets more mechanisms in there than 2 drugs full dose. So really in this setting, we have a couple of options, including PVD or DVD. And again, if you look across the board, except for a couple of areas, DVD is going to be one of the best regimens. And remember that the Velcade wasn't given to progression. It was only given for around 6 to 7 cycles, and then patients continued on single agent Dara. So this patient remains Velcade sensitive. You can use that as part of the next line of therapy if they need one. Now, we've all become to understand that carfilzomib is probably the most potent approved proteasome inhibitor. Now, one of the issues with carfilzomib is how do you give it? Do you give it once a week? Do you give it twice a week? Do you give it over 2 to 10 minute infusion? Do you give it over a 30-minute infusion? Do you give it at 20 milligrams, 27, 36, 45, 56, or 70? So the dosings are all over the place. I can tell you that the majority of practice in the US is to give once weekly carfilzomib at 56 milligrams per meter square. Seems to kind of have that Goldilocks range of lots of efficacy without too much toxicity. And again, what you combine it with can be very potent. Combining it with a CD38, as we've seen in the IKEMA and Candor study, have shown some of the best PFSs, although not on here. We now know that the median progression-free survival for that bottom one from IKEMA is around 40 months. So very impressive. But again, that's a patient that's CD38 naive or sensitive. Same with Kyprolis. Otherwise, a lot of things we can combine it with. And again, let's not forget pomalidomide. Pomalidomide could be a great base of different therapeutic options because it combines well with everything. Even going back to the original Dex, there's now, oh, I don't know what happened there. Cidex is a good all-oral option with activity. And again, Darapom or Isapom. The really nice thing that we're starting to evaluate is that pomalidomide and Revlimid, we have to remember they're IMiDs, they're immunomodulatory drugs. So one of the things that we're starting to use in the US is low doses of pomalidomide combined with bispecific antibodies, not in order to kill myeloma directly, but to augment that T cell response. Because remember, POM augments NKT responses. So using 2 milligrams in a bispecific will allow you to kind of ramp up the bispecific use. And we have some nice ongoing studies looking at that. So what happens, if we wanted to compare the different regimens with pomalidomide, Isapom, Elopom, Darapom, again, it's hard to compare trial to trial because there's significant differences. But if you look at Acaria versus Aquelius, there were more average lines of prior therapy in Aquelius. So that is part of the reason why the PFS is a little bit lower. But again, combinations with CD38 and pomalidomide seem to be the most potent overall. Elotuzumab is a nice drug. However, it's of limited utility in modern day myeloma because ELO requires NK cells to kill myeloma. That's how ELO works. It turns out that all NK cells express CD38. So if you give a CD38-based regimen using daratumumab or isatuximab, and then that stops working, trying to use ELO won't really work because those NK cells have all died. Now, I don't think we can really talk about relapse myeloma without talking about Dara quite a bit. And apologies, I have no idea why this click to edit master slide styles is on there. I am sure I clicked something I shouldn't have. I will fix this in post, I hope. But if you are naive or sensitive to a CD38, daratumumab-based combos are going to be some of your best bets. Again, very durable remissions, very combinable in 3 and even 4 drug regimens. And in many ways, daratumumab has become the Rituxan of myeloma. We have many patients in the lymphoma world that are too old or frail to receive chemotherapy. We can still give Rituxan. Or if we have a regimen, adding Rituxan to it makes it better. Same thing with Dara and ISA, that adding a CD38 antibody makes any of these regimens better. So, if we're looking at early relapse, so 1 to 3 prior lines, and we want to avoid an IMiD, as the backbone. We have a number of trials here. And again, some of the best ones that we see are when we combine CD38 and Kyprolis. So really, ISA KD and DARA KD are going to have some of the best outcomes. Again, Bellini is great, but that requires access to venetoclax. Where do I use ISA KD and DV and DKD? In the people that I'm really worried about. If I put somebody on Revlimid maintenance after auto transplant and they stay in remission 6, 7 years and they relapse, I'll give you Darapom, no problem. If I give you an auto transplant and Rev maintenance and 6 to 12 months later, you not only progress but have extramedullary disease or more aggressive disease, I'm going to lean towards something like ISA KD or DKD because I think that's the type of patient that needs that more aggressive regimen. And the other thing to remember is, in myeloma, we talk about classes, and there are the 3 core classes of therapies: IMiDs like Revlimid and Pomalyst, PIs, proteasome inhibitors like Velcade and Kyprolis, and monoclonal antibodies like Darzalex and isatuximab. And we recognize that, becoming triple class refractory is happening more frequently and earlier on in the current paradigm of myeloma. I'll never forget an early on consult that I had in my career many years ago now, where I was sent a patient from the community that had 5 lines of prior therapy. And the patient had Revdex, then Pomdex, then Veldex, then Kyprolus-Dex, then Daradex. So it took them 5 lines of therapy to be triple class refractory. Now, if you get in the US Dara RVD up front and progress, you're triple class refractory in the second line. So really important to kind of evaluate what are some of the options that are moving beyond, the classic 3 classes, the traditional classes of IMiDs, PIs, and monoclonals. And the reason is once you become this refractory, the general data is not that good. So if we look here, and this is the mammoth data, and this looks at people that were triple, quad, and penta refractory. Penta refractory literally meaning refractory to Rev, Pom, Vel, Kyprolis, and Dara. And if you are penta refractory, your median overall survival is 5.6 months. So it's very important from a myeloma community standpoint to explore what options we have to make that number a whole lot better. And again, I talked a little bit about elotuzumab, and this is some of that data looking at ELO after CD38 refractoriness, remembering that ELO needs those NK cells. And we look at this data, and the response rate was about 20%. Small numbers, but 20%. No one having anything deeper than a partial remission, median progression-free survival of 2.5 months. So again, ELO is generally not going to be our go-to drug in a CD38 refractory patient. So now this slide's a little busy, but really what I want to bring about is that, we very readily think about those core 3 classes early on in myeloma. And the question is, once we start going beyond them, we need to look for other classes. We need to think about the BCMA agents, the GPRC5D agents, small molecules like selinexor and venetoclax to really optimize outcomes in these patients. So let's take a look at selinexor because I think we have some good data on it. And really what I want to expound upon is that, this is the main slide that was presented and published as part of the approval for the Boston regimen, selinexor Veldex versus Veldex. And yes, it met its primary endpoint of around 14 months over 9.5 months. But this is not all that helpful. This is helpful. The question is, when we're at the bedside with a patient, we're trying to make a decision at that inflection point. Who is the type of patient who is going to do better or not? Because you look at the overall, in the ITT arm, you had PFS of 14 months. But um, when you take a look at the data here, there are subgroups of patients that had 21 and even 29-month PFS. So I want to get a little granular because we do see these patients, and I'd prefer to use XVD or SVD in a patient that's more likely to get the big time response. So let's take a look. And this is the median PFS and responses for PI naive patients. And if you look across the myeloma history for the last several decades, bortezomib-based regimens, whether or not you're in Canada, US, anywhere in the world, transplant eligible or ineligible, Velcade has been the core of our regimens, right? VCD, VTD, VMP, VRD, DARA, VRD, VMP, VCD, VTD, you name it. But with the Maya regimen, DARA, Rev, Dex, we have a rising cohort of patients that are PI naive going into their second line. So what happens if you take someone who's got maybe DRD up front and didn't do well with it, and you want to have two new classes? This data here, we look and we see a very modest improvement in overall response rate from around 70.8% to 76%. But we see an improvement in progression-free survival that's almost triple from 9.7 to 29.5 months. And the reason is the depth of response. You have more people getting VGPRs, more people getting CRs, because it's all about getting that depth. So to me, I'd rather give somebody dose-adjusted SVD than full dose Veldex. Now, we don't really know how to sequence all of our drugs in myeloma. We sequence drugs at the current time based on when they were approved and what our regulatory agency allows us to give at what different lines. But a group from Moffitt in the US tried to see what the relationship of genomic predictors of resistance were between CD38s like daratumumab and selectors inhibitor of nuclear export like selinexor. And they found a yin-yang relationship that resistance to one predicted response to the other and so forth. So they asked the question, all right, well, if that's the case, let's look at some of our data from our studies about people who received selinexor directly after progressing on a CD38 regimen. And this is two curves, one from the STOMP trial, which looked at patients who had selinexor POM and selinexor Kyprolis after daratumumab, and the Export 28 study looking at a very similar study like the XVD arm. And if you look at the gold versus the blue lines, the gold lines are the people who had immediate prior CD38. So there seems to be something about priming the pump and predicting for response for selinexor-based therapies in people progressing off of CD38. And if you look at this waterfall plot of XPD and XKD patients, and remember, those asterisks are for the high-risk cytogenetic folks. Those are the del 17Ps, 414, 1416, gain 1Q. It's a pretty impressive waterfall plot. So again, XVD, if I had to put XVD up against ISA KD head-to-head, ISA KD will probably win. But if I had to give XVD, if I had a patient who had a CD38, I'd rather give him XVD and then ISA KD because A, K does better after V than before, and B, it takes about 4 to 6 months to repopulate CD38. So if you had DARA, then you get a sandwich regimen in between, you have time to repopulate CD38 for ISA later on. And then we'll talk a little bit about venetoclax, and we recognize that venetoclax, which is approved for myeloid and lymphoid diseases, doesn't really have any single agent activity in myeloma except for patients with 1114 translocated disease. So we see some data here from Nizar Baylis. Oh, wow, more Canadians. All right, love it. Love it. So here's some data from Nizar looking at venetoclax Daradex versus DVD in early relapse. And again, these are for patients with 1114 translocation. And we see the improvement in overall response rate from around 65 to 96%, with a median progression-free survival that goes from 15 and a half to over 46 months. So not only is this a very effective regimen, but we also have data now to suggest that Additional high-risk cytogenetic acquisitions like 1Q gain and 17p will mitigate some of the response rate of venetoclax in 1114 patients. Because 1Q is the most commonly acquired genomic mutation in myeloma, what this tells us is that trying to use venetoclax in the eighth line not going to work very well because more likely to have additional acquired cytogenomic abnormalities. So we have patients in the second or third line with 1114. This is where we like to give venetoclax-based therapy, and we see great outcomes here from Nazar's work. Now, we can't talk about relapse myeloma without talking about T-cell redirection. So we'll talk a little bit about two of the big CAR Ts, ide-cel and cilta-cel. And this is more recent updated data from the KarMMa-3 study, which looked at patients who had triple-class exposed relapse myeloma, 2 to 4 prior lines, and compared standard options in myeloma versus ide-cel. And we see a significant improvement in response rate from around 42 to 71%, and an improvement in progression-free survival from around 4.5 to 14 months. But what is really kind of changing the game here is cilta-cel. This is the CARTITUDE-4 study, similar but different. CARTITUDE-4 was 1 to 3 prior lines. And also of note, in KarMMa-3, patients were allowed to cross over. There was no crossover on CARTITUDE-4. And here we see an improvement in overall response rate up to 84.6%. And if you look at the people that actually got the CAR T, because there are a couple of people early on who didn't, but everyone who got a CAR T, there was an overall response rate of 99.4%. Basically, only one person didn't respond. And again, the median progression-free survival is not known, but it looks like it's going to be something in the many years, and you can drive a truck through those PFS curves. Now, belantamab mafodotin was a previously approved BCMA antibody drug conjugate based off of the DREAMM-2 study. When DREAMM-3 came around, which compared belantamab versus Pomdex, Pomdex was found to be better, and this was taken off the market. However, in the last few months, we've seen presentations and publications of both the DREAMM-7 and DREAMM-8 protocol. DREAMM-7 was belantamab Veldex versus Dara-Veldex, and DREAMM-8 was belantamab Pomdex versus pomalidomide Veldex. Both of these studies read out positive and are likely to lead to reapproval within the next year. So if we look here at the DREAMM-7 data, and we look at median progression-free survival, 13.4 versus 36.6 months with BVD, and we see that holding through with OS as well. And the importance here is really interesting, is that, I spoke recently at a convention, and they were saying, well, what's the point of belantamab if we have bispecifics and CAR Ts? And I said, well, let's take the current landscape for older patients without access to major medical centers. And if you look at the current quad data, so IMROZ and Cepheus, ISA-VRD or Dara-VRD upfront for transplant-ineligible myeloma patients, the median progression-free survival is 90 to 100 months. If you follow that with something like belantamab Veldex, where the median progression-free survival is over 36 months, we're now talking about 130-month median progression-free survival. That means if you have an 80-year-old that gets diagnosed with myeloma, the likelihood is that they will not die from myeloma, and they will not need to be admitted to the hospital, get a stem cell transplant, or lose their hair. So really a great drug with a lot of possibilities. Now we see here from the updated data from Thanos Dimopoulos, the DREAMM-8 protocol, belantamab Pom versus Pom-Veldex. And I guess this really mimics the Algonquin-1 study by Suzanne Trudel. I'm going to throw as much love to the Canadians as possible. Again, please don't hate me because I'm American, but Suzanne Trudel doing some amazing work with Algonquin-1, where she also gave belantamab Pomdex. And again, we see here PVD versus BPD, a marked improvement in progression-free survival, with the median progression-free survival not yet reached, but likely in the 3-year range. Again, 3 years from a regimen that does not require admission or high-dose therapy, very potent type approach. And kind of taking the 10,000-foot view is what happens when we get to triple class refractory, triple class exposed. And I love this diagram or infographic from Bruno Costa, and basically saying, all right, we've gone through those three big classes. Is the patient eligible and or are available to get CAR T or bispecific? If the answer is yes, give it. If not, is belantamab available? No. Yes. Yes, give it. But again, BCMA is really our first approach for that setting. Let's say those are not available or not available just yet. Selinexor is going to be a really great next approach. And the question is, what do we combine it with? Because we recognize, again, triplets better than doublets. So SKD, SPD, DARA, SD, all excellent regimens. Does the patient have an 1114 translocation? If they do, let's get venetoclax in there. And then ultimately, we're heading down the pathway of, do we need to give chemotherapy? Or do we need to give chemotherapy with cells back? So, because if you give something like bendamustine, hydrocyclophosphamide, VD-CEP, or any of those regimens without stem cell support, you're going to hurt your T cell fitness. So, following up bendamustine with a bispecific or a CAR T is not going to get the job done. And really just kind of rounding out what's coming up on the horizon. We have a number of great new targets that we're looking at in myeloma, BCMA, GPRC5D, and FCRH5, and we're looking at them across a variety of modalities, including antibody-drug conjugates, bispecific antibodies, and CAR T therapy. At the moment in the United States, we have 3 FDA-approved bispecifics, teclistamab, talquetamab, and elranatamab. We are likely to have a 4th approved on or before July 10th of this year with linvoseltamab. The current approval is patients with relapse disease with at least 4 prior lines of therapy, including a PI, a IMiD, and a CD38. Teclistamab was approved based off of the Majestic-1 study. We give the bispecifics in step-up dosings so that we can minimize the risk of cytokine release syndrome or ICON. So instead of giving the full immune response all at once, we ratchet it up. And overall, we saw a response rate of over 63% with a median progression-free survival of around a year and a median duration of response of around 18 months. It's important to note that these patients can get significant hypogammaglobulinemia and infections. So making sure patients are kept up to date with their vaccines. We provide IVIG, as well as prophylaxis against with acyclovir and PJP prophylaxis with Bactrim or equivalent. Elranatamab is also approved based on the Magnetism-3 study from Alexander Doshokin and Mohammed Moti. And we see here very similar data to teclistamab, around a 61% response rate, median duration of response not yet reached, but probably a little over a year. And again, the main toxicities of CRS and ICONs. CRS tends to be low grade and easily managed with steroids and or tocilizumab. ICONs tends to be rare and no permanent manifestations of either. GPRC5D, which I know was recently filed for and I believe rejected by Canada, by CDA, but I believe it's being refiled, is the rumor I heard. I don't know if anyone on the call knows better than I do, which is probably everyone. Talquetamab targets GPRC5D, which is another ubiquitously expressed antigen on all myeloma cells. In the US, it was approved with 2 doses. Both have to get ratcheted up to either 400 micrograms per kilo to be given weekly or 800 micrograms per kilo to be given every other week. Response rates of around 73%. Important thing to know is that GPRC5D is expressed on other cells besides just plasma cells. So it's expressed on the squamous epithelium of the hands and feet. So people can get a desquamating rash, which looks like a Zolota rash. It's on the oropharynx and salivary glands, so dysgeusia, anorexia, xerostomia can be seen. And there's recently been discovery of some neurological expression potentially in the cerebellum, which may lead to things like ataxia or dizziness. We have a number of ongoing clinical trials, and I apologize because to give you an idea of how fast myeloma is moving, if we go left to right, linvoseltamab, is now going to be approved in the next 2 months under the name Linvoseltamab. Regeneron 5459 is no longer being pursued in myeloma. Alnuctamab is no longer being pursued in myeloma. TMB 383 was purchased by AbbVie, now ABBV 383, recently named Etentamig, ongoing clinical trials with that. Cevostamab is an excellent study, excellent drug. Wonderful presentation at this year's ASH by Dr. Richter on the latest data in cevostamab. And unfortunately, Farimtamig is no longer being pursued in myeloma. Where are we headed towards CAR T therapy in the future? Couple of really interesting things to look at. This is looking at CAR T therapy just in general. This is the original CARTITUDE-1 study. Again, we look traditionally at responses in heavily relapsed myeloma to be around 30%. Bispecific antibodies have been 60 to 80%, and here comes CAR T at over 97%. Kind of amazing stuff. Again, patients had a 2-year progression-free survival rate of 55%, and those that achieve MRD negativity do the best. What about using other targets? So this is a GPRC5D CART, now entitled Arlo-cel. Very efficacious drug and new target, so may have fewer infectious complications, but again, still trying to sort out all of the neurotox that we see. Again, it's not common to get this ataxia, cerebellar toxicity. It is rare, but it's unfortunately not quite reversible yet with the CAR T, so we're still trying to sort that out. What about rapid production manufacturing? So right now we have what we call a brain to vein time, not just vein to vein when we draw your T cells to when we can give them back, because it can take about 2 months sometimes for that to happen. But brain to vein time means I think about giving a CAR T, I have to stop the therapy you're getting. I have to give you time off. I have to collect your cells. They have to be manufactured. You have to get bridging. The cells have to go under quality control. We then have to give lymphodepletion and then give the cells back. What about rapid manufacturing? And if we can get the manufacturing time down to less than 2 days, can we basically make this a pseudo off-the-shelf phenomenon where we can actually get patients to CAR T very quickly? What about dual target CAR Ts? So the Gray Cell platform looking at BCMA and CD19 as a platform. We note that the initial therapy studies of CAR Ts in myeloma were CD19, which was the same construct that was used in lymphoma and leukemia. It didn't work all that well because CD19 is not readily expressed on myeloma cells. However, CD19 is theorized to be expressed on myeloma stem cells. So in this way, if you attack the myeloma stem cells and the myeloma, maybe it's like chopping down the tree and poisoning the roots. So we're very excited to see what this long-term data looks like. Ultimately, though, we like to say that diseases don't have to read textbooks, so sometimes we can't wait at all, and we just need an off-the-shelf product. What about allocars, completely off-the-shelf CAR T therapy? There have been a reduction in a number of studies looking into this, but again, very impressive response rates so far. No real evidence of GVHD, so we're still continuing to monitor, but it may be a great modality for the future. So really where we're at in the final moments is, this has kind of been the paradigm over the last decade of, we give you initial therapy and we get you in remission, and then we have remission, relapse, and ultimately towards the end, we have very few good options. And I love this slide that was put together by Tom Martin of UCSF is where are we headed from 2025 to 2030? And we're really going to enter some new territories. So giving quad up front, plus or minus transplant or CAR T, and maybe instead of giving people therapy forever, we can use MRD-based assessments and immunologic-based assessments to see who we can stop. And maybe even cure some of those people. And if the disease does come back, invoking novel approaches like novel CARs, ADCs, bispecifics, trispecifics, CRISPR strategies. So really working our way to either extremely durable remissions, if not cure in some, and hopefully one day cure for all. And with that, I will thank you very much and take any questions, comments, concerns, or complaints.
Thank you, Dr. Richter. We very much appreciate you being here. And yes, we do love you, our neighbors to the south, despite all the things. Thank you for also acknowledging the work that your fellow Canadian colleagues are doing in the myeloma space. We are very proud of our folks up here in the north and what they're doing. We do have quite a few questions in the chat if you're all right with that. No complaints, zero complaints, I will say.
Wonderful. All right.
Okay.
Fire away. All right. Question.
Okay, so we've got one of our support group leaders, Bob. He's asking two questions. So one of the questions he's asking is, are the medical teams in the U.S. as concerned as we are with regards to tariffs on cancer medications? And question number two is, do you see a day when Dex is not part of treatments?
Ah, all right. So the first question is, we're currently concerned about everything. That's just kind of the way we are. I think everything is a little unpredictable. That being said, I can tell you the motto at our institution is we find a way. And at the end of the day, we have a lot of support. And for what it's worth, I have a patient that young woman was all of a sudden developed her entire lung filled up with cancer, myeloma. We had to admit her, we had to give her talquetamab. Her insurance wouldn't approve it. And she made enough money where they said, no, we're not going to give you, like, there was no support, there was no nothing. And it was the only drug that was going to work for her. I worked with the team, the company that makes it, and they gave her a free drug. So at the end of the day, with a little extra conversation, communication, and advocacy, we can find a way. And so, yes, I'm concerned about all of this. The last thing that the medical system needs is more money and more pressure and less focus on patients. But we will always find a way, one way or another. So at the end of the day, I'm sure that we'll persevere through this too. As far as the decks, that's a brilliant question, and I couldn't agree more. There have been some amazing, for those of you who are on Twitter or X, whatever they're calling it this week, people like Rahul Banerjee and Vincent Raj Kumar, the Down with Dex campaign. Yeah, I think back in the day, Dex was a very key drug because you needed it to synergize with everything. But now we recognize that long-term DEX is a problem. So we use it in the beginning and then we start to get rid of it. So I think the future, and there have been a number of studies not using it at all, is that DEX will be a supportive care med, meaning when we give something like DRD, DARA Rev Dex, it'll just be DARA and Rev and only give Dex when we need to manage symptoms or manage CRS or manage side effects. So, yeah, I think it's a wonderful thing that we're slowly moving away from Dex being the true core of all myeloma therapy.
Okay. We have another question from one of our leaders, Sandra. She's asking in the Dara-Len-Dex maintenance, when can you reduce the dose of Len if you're handling it well? Do you have to stay on 25 or at some point do you reduce it?
Wonderful question. All right, I will answer this one as well. I love to tell stories. So, back in the good old days, old spelled OLDE, the standard of care for myeloma patient was what we used to call Big D. No jokes. Big D was dexamethasone, 40 milligrams a day, 4 days on, 4 days off, 4 days on, 4 days off. Well, eventually Revlimid came on the scene and they started combining them, and they're like, wow, our Big D is great, but maybe our little d could be better. And they said, all right, we'll do our big D versus our little d. And big D was 40 milligrams a day, 4 weeks on, 4 days on, 4 days off, 4 days on, 4 days off. Our little d was 40 once a week. And our little d was better than our big D. So our little d became the standard. And then a brilliant doctor by the name of Alexandra LaRocca out of Italy said, well, this is nuts. And she knew I was going to be talking today. And she said, I want to figure out a way to combine the last two questions in one answer. So she did a trial a couple years back of R big D versus what she called R little d dash R. Sorry, R little d versus R little d dash R. And what she did was take newly diagnosed patients and gave them, they either got the standard, which was Revlimid 25 and Dex 40 once a week, and they just stayed on that. Or what she did was gave them that for 9 months, and then at month 9, got rid of the Dex and dropped the Rev from 25 to 10. And in her study, the RDR did better than the RD. So How I extrapolate from this is that if I have somebody on DRD long term, after around 9 months, I consider dropping the rev from 25 down to 10. Now, patient specific. If I've got a young patient who has no side effects on Rev 25, do you have to, and it's high risk disease, do you have to drop to 10? No, but for many patients, based off of Laraka's RDR data, after 9 cycles, I drop the Rev limit down to 10 milligrams.
Okay. Thank you. We have a question now actually from one of our staff members. Our Director of Science and Research, Gabe, is asking, in your clinical practice, do your transplant ineligible patients generally get DRVD or DRD continuously, or do you de-escalate using MRD?
This is a wonderful, wonderful question. So I think it's a discussion. So there's been a couple of studies now showing that quads are better up front. So Cepheus, giving Dara VRD followed by Dara Rev, is probably one of the best ways to go for patients. I do not keep people on continuous quad therapy. I think that is unnecessary and ridiculous. So to me, if I have somebody who's older, frailer, let's say I have a 90-year-old, if you put a 90-year-old on Dararev Dex, the median progression-free survival is 60 months. That's a very, 5 years average remission on DRD is pretty good. Um, but someone that you need to get more longevity, I give them Dara VRD, give them 4 to 6 cycles, get them into a deep remission, and then switch to Dara Rev. And then I keep them on Dara Rev long term, once a month Dara, long term Rev. I am not yet convinced that MRD is at a point where we can granularly say for an individual, is it okay to de-escalate? Because we have patients that get MRD negative and then relapse. We have people that never get MRD negative and do amazing. There is this study called the Dramatic Study with two M's, also called SWOG 1803, being headed by Amrita Krishnan of City of Hope. And she's looking at patients after auto transplant randomized to Dara-Rev or Rev maintenance with MRD stopping rules. And we will have a readout in about 3 to 5 years. But at the current time, I do make the decision clinically. Meaning, if I have someone on DRD and they're 3 years out and they have no trouble and they're doing great, I keep it going because the data right now says keep it going. If they're having trouble despite supportive care and dose adjustments, I stop it. Because to me, if you're MRD positive but you're miserable, I'm not going to keep going. And if you're doing amazing, just because you're doing amazing and MRD negative doesn't mean that if we stop it, it won't come back. So I am not yet at the point where I use MRD to start or stop.
This is actually a related question that's come from one of our leaders, specifically Peter. They noticed that they noted that they are MRD negative for 2 years post stem cell transplant, and they're on Dara-Rev maintenance. What factors do you consider in continuing or stopping maintenance?
Yeah, so, if you look at studies like Perseus and Griffin, a lot of those studies gave 2 years of Dara and Rev and then switched over to Rev alone. Um, I think this is a really difficult question and is really risk-benefit discussion with the patient and their care team. The factors that I use are what component of high-risk features does the patient have? Meaning, is there extramedullary disease? Meaning, if you have EMD at diagnosis, that's a high-risk feature. The MSMART guidelines, so if you go to msmart.org, the Mayo Clinic keeps an updated list of high-risk cytogenetics. And one of the things that's been really interesting is a study called the MASTER study. And MASTER was run by Luciano Costa, and he gave people Dara KRD and Dara Rev maintenance. And when they had MRD several times, he stopped therapy. And then he went back and looked at the data and he grouped the patients into 3 groups. No high-risk cytogenetic abnormalities, one high-risk cytogenetic, or 2 or more. And the people with 0 and 1, even when they stopped, tended to do well. Very few relapsed. The people with 2 or more high-risk cytogenetic abnormalities, they relapse sooner. So the question is what to do after 2 years post-autograft on Dara-Rev maintenance. Do I consider stopping? I think that if you have high or ultra high risk, either keep the Revlimid going or keep the Dara and Rev going. I think that if you have standard risk and maintaining MRD negativity, I think the dramatic study will let us know who to stop. But right now, I at least continue the Revlimid after 2 years for people in that scenario.
Okay, we just have a couple more questions. So for those of you who are still putting questions in the chat, in interest of time, we're not going to take any more questions now, but we do have a few more if you're all right with that. Is that okay? Okay, okay. So we have another question from one of our leaders, Claudia, who's asking, with the many new triplets and quads that are coming out, do we have research or data that specifically tracks if a patient stops treatment due to toxicity of the regimen, so example, quality of life, or the treatment was not successful in those patients? Because oftentimes toxicity is overlooked when compared to progression-free survival or overall survival rates.
Yeah, I think this is an absolutely wonderful and critical question. And in fact, right now I am working with the International Myeloma Working Group, of which people like Hiramiyan are part of. Another Canadian, got to throw some love to the Canadians. And we're trying to put together a consensus of how to evaluate quality of life metrics in regard to clinical trials. Because there's a lot of different ways to do it, but there is no agreed standard version of it. Because as this person asked, you know, intolerance and quality of life, they mean different things to different people. And how do you incorporate that and to figure out what regimen might be better in terms of progression-free survival and so on? So, in fact, there was a meeting this morning from that group. I was rounding in patient, I couldn't go, but had our 3 meetings so far. We're putting together a manuscript to help codify clear guidelines for all myeloma protocols to include this as a standard approach to exactly address this, because right now it's all over the map.
Okay, and just two more questions. So we have a question from Susan. How commonly does neuropathy limit third line choices?
Wonderful question. So, in general, not so much now. I think that in general, although our ability to treat neuropathy has not dramatically changed in the last 10 years, our therapies have. So we used to give intravenous bortezomib twice a week. Now we tend to give subcutaneous bortezomib once a week, much lower incidence of neuropathy. Thalidomide is not used nearly as commonly. POM and REV rarely cause neuropathy. They can. Elranatamab can cause a little bit, but not too much. So in general, neuropathy does not limit a lot of our third line choices, mostly because uh, Velcade is usually, we've gone beyond Velcade at that point. Oh my goodness, I am so sorry. I must be very popular today. Um, and thalidomide isn't really used there. So I don't, again, everything is risk benefit. So let's say you have a drug that causes neuropathy in a patient that has neuropathy. Would I use it in first or second line? No, but because I think there are other options where the benefits would outweigh the risks. But having a discussion with the patient in later line and say, listen, we don't have a lot of options. We do have this one. It's a risk of neuropathy. You discuss the known reversibility of that. And it has to be a risk benefit discussion with the patient.
Okay, and last question, I promise. Thank you very much. Is coming from Helen, and the question is, how many patients, I mean, you probably don't have something specific in your mind, but just generally, how many patients present with tumors? And if you have tumors, does that mean you're a higher risk?
So we have to define this a little bit. So I'm assuming you mean myeloma-based tumors. And we use a couple different terms. So the common term that we use is EMD, or extramedullary disease. But there's actually several different versions of this. And kind of the newer terminology is paramedullary versus extramedullary. Paramedullary means there's a soft tissue tumor, but it's coming out or is intimate with the bone. So think about the bone where the tumor grows and grows and now spills out. That's paramedullary disease. Extramedullary is where the tumor is in a soft tissue having nothing to do with the bone, like in the breast or the thigh. Paramedullary tends to behave like regular myeloma. Pure extramedullary tends to behave worse. And yes, that is now considered a high risk feature if you progress with EMD right off the bat. That doesn't mean that we don't have ways around it. It doesn't mean that we can't treat it, but unfortunately, it is considered a high-risk feature nowadays.
All right. Thank you, Dr. Richter. Martine, I'm gonna turn it over to you. I know you're here. Dr. Richter, I don't know if you are aware, Martine is our CEO here at Myeloma Canada.
Ooh,
Um,
Thank you.
I'm
Thank you,
honored.
Chantal. Thank you, Dr. Richter. It's been a wonderful presentation, and I love the fact that you spoke very slowly because there's a lot of letters and acronyms and a lot of terminology which is not always familiar with us. But I can recall when I started working in the myeloma field, there was only one letter, and that was T for thalidomide. So now that we have a whole new alphabet, it's actually quite reassuring, and it's actually quite heartwarming that you have so many options that you can offer patients, to the point where you don't always know what options. It depends on this, it depends on that. And so the conversation with the patient must be really so important as you continue to advance treatment. And what I really loved also in your presentation, that you used the word cure. We didn't used to hear that when I first started in this area. Now we hear it more and more. So thank you very much for your time. And thank you for, being who you are. And thank you for apologizing. This is kind of really unusual for Americans to apologize to Canadians, because usually we're the people who are the apologizer. Well, I can't say this word in English, but we apologize a lot. So thank you for that. And yes, we will always be friends with our Americans. And have a great day. And your patients are lucky to have you.
It's very kind. Thank you guys so much for having me. We'd love to work together in the future.